Hi, my name's Kath. I'm a trainee advanced clinical practitioner in a couple of emergency departments in the north of England, paramedic by trade, and I read the Emergency Medicine Journal, so you can pretend you have. I'm up to April 2025, I'm catching up, we've only at 2 behind now. So what does April 2025 have for us? Well, it's got a pre-hospital trauma focus, woohoo! So, we've got out-of-hospital cardiac arrests, we've got trauma-induced coagulopathy, we've got hemothoraces, lots of exciting stuff, and we've got another use of ultrasound to add to the list, which I said I was going to do, and I've done. So, let's get into it. First bit is a commentary piece by Professor Karen Brohy, off of London, who is talking about taking major trauma care or trauma care beyond protocol-driven approach, like how can we make it more personalised for our patients? So, for example, major hemorrhage protocols are very standardised. Can we start adapting these to the patient? So can we start tailoring it depending on their injury, their age, their sex, their pH on arrival, their temp, and they're looking at what guides decision making. They talk about using support systems in real time. Is this AI, is my question. So this got me thinking about AI. Also, they know AI was used to review the flow and consistency of the final draft of this commentary. So possibly a big AI fan writing this. So yeah, I guess, is there a future where we are coming up with really tailored care plans for patients based on algorithms and AI? And is that good? I mean, I guess it's good if it improves outcomes. Could it lead to this situation where we get the kind of decision making is a bit opaque because it's maybe more complicated than we can understand in the moment or ever? And how do we feel about this? This isn't a hypothetical question. I don't know, and I'm thinking about it. Since I started making these videos, we now have AI assist in chest x-rays. It comes up with like the AI commentary for you to refer to. And as someone that's relatively new to interpreting chest x-rays, I don't know how I feel about that. It's like, am I de-skilling before I've even got started? And like, what's the temptation to look at that first and then look at the x-ray? I had a patient with new AF the other night. So I was trying to initiate anticoagulation meds, and as part of that was calculating various scores to assess risk factors. So as recommended was doing my CHADS-VASC score, the most manosphere sounding of scores you can do, CHADS-VASC, and an orbit score. So that's looking at like risk of stroke, risk of bleeding after anticoagulation. And a lot of that, we do loads of scoring, don't we? Like I've got that MD Calc app and do loads of scoring, and sometimes it all makes sense, like a Wells PE score is all quite straightforward. Other times it's using blood test results that I'm kind of just putting in like a robot. So I guess there is a level to which we're already guided by, we've kind of outsourced that decision making in a way that's sensible because we're not robots and we have limited capacity. So we've already kind of do that, don't we? But then, yeah, is there a potential that AI will kind of accelerate that? I don't know. That's my takeaway from this piece. Don't know. Interesting though, isn't it? So the path to precision trauma care, what's that going to look like? What's the future going to look like? How is AI going to come in, and do we like that, or do we have complicated feelings about it? Next up, right, this sounds so dry and it's actually interesting, and please bear with me, but the next paper is original research. It's called Comparison Between Point of Care International Normalized Ratio, COAST, TICS, and truncated FIB-AT scores to rule in clinically significant hypofibrinogenemia in the pre-hospital setting, by Bodnar et al. Off of Australia, I think. Right, I know that's dry. So we are talking about trauma-induced coagulopathy in general. So trauma patients, they lose the ability to form clots or maintain clots. It's associated with really poor outcomes. Part of this is hypofibrinogenemia. So anemia at the end suggesting it's something to do with blood supply, right? Hypo, it's low. Fibrinogen is fibrinogen. So this fibrinogen is a protein produced by the liver, which is then converted in the body into fibrin, which forms clots. So hypofibrinogenemia, easy for you to say, is low fibrinogen level in the blood, which leads to an inability to create fibrin to form clots. So that's what we're talking about. Low fibrinogen levels are part of trauma-induced coagulopathy, but actually there's loads of moving parts. We don't totally understand it, but we know that if someone has low fibrinogen levels, then they are more likely to have trauma-induced coagulopathy, which are more likely to have rubbish outcomes. So that's the scene we're setting. One small rabbit hole. I was like, fibrin, because I'm not going to lie, I looked some of this up to make sure I was explaining it properly. And fibrin just seems like something we probably found out about 50 years ago. It was discovered in 1666 by a guy called Marcello Malpighi. Sorry, Italians. He's Italian. I suspect that's not how you say his name. But basically in the 1600s, so the microscope was invented in the early 1600s and no one really did anything with it for a little while. And so then there was a few like pioneers, including this guy, Marcello, who just spent like their whole lives looking at stuff under microscopes. So he discovered fibrin because he was looking at blood under the microscopes, or scabs, I don't know, but also discovered loads of other stuff. He was the first person to describe nerve endings in the human body. Where did he get those bodies from? He described like grey and white matter in the brain. Where did he get those brains from? He was looking at lungs. He was looking at loads of plants and trees, blood. He discovered galls on trees were like a response to an insect rather than just like a natural thing the tree produced. Like the list of stuff he like described and discovered is super interesting. Loads of it is named after him. If you like a rabbit hole, and I suspect you do because you work in emergency medicine, so your attention spans are possibly not entirely in the middle of the bell curve of the general population, look up Marcello Malpighi because that was cool. Anyway, right, so he discovered fibrin. Now we know fibrin comes from fibrinogen, and we know that low fibrinogen levels are associated with poor outcomes. We're back in the room. Okay, so this test was basically saying... on paper, fibrinogen supplementation in trauma patients should lead to better outcomes because it's maintaining the body's ability to produce clots, and it's going to mean that there's lower levels of trauma-induced coagulopathy. But it hasn't really. They've done some trials where they've just supplemented everyone, and they found no clinical benefit. So the next thought is, well, can we be more targeted with who we're providing fibrinogen supplementation to? This research is about like, how do we find those patients? How do we identify low hypofibrinogenemia pre-hospitally? So they tried all these different ways of testing it pre-hospitally, different ways of testing it, some of which are point of care testing. So international normalized ratio, also known as INR. So point of care INR. Then there was also like a stratification tools, so scoring systems and things like we were just talking about. Because they think that early correction will lead to better outcomes. So the study was comparing those tools, and they found that the only one that had statistically significant discrimination was the point of care INR testing. So this isn't saying, this is early days basically, saying this is a good way of picking up low fibrinogen levels pre-hospitally. What it's not saying is then treat this, there's good outcomes. On paper, that should work, but actually the situation we're at is that's all ahead of us and research is needed. But it could be something that comes in future. So useful to know from a pre-hospital perspective, and also kind of feeds into the previous article about the path to precision trauma care of like, this is exactly the kind of thing that can lead to more tailored. So we know it doesn't work to give everyone fibrinogen supplementation, but can we be tailoring it based on their INR levels? If their INR levels are off, we supplement. So yeah, kind of part of that. It's the future, and maybe you'll have a point of care INR testing available pre-hospitally at some point. So next one is conservative management of traumatic haemothoraces, a UK single centre trauma unit retrospective audit. So they look back on patients with traumatic pneumothoraces who were admitted to a single trauma unit on Northumbria. Worth knowing, it's not a major trauma unit, so the poorly patients with haemothoraces were not going here. They were bypassing and going to a tertiary centre. So they reported the incidence of pleural infections in patients who didn't get a chest drain from January 2022 to September 2023. So haemothorax, so blood in the pleural cavity. We put chest drain. I noticed on the last video whenever I talk about chest drains, I'm like, so chest drain, that's where it goes in. So people with haemothorax put chest drain in, drain that blood out, with the thought that that reduces the risk of infection from blood in the sterile pleural space. That's the rationale for putting a chest drain in. Although also when you create a tunnel between your pleural cavity and the outside world, there's also an infection risk there. So like most interventions, it's not risk-free, you have to balance them. So this hospital took an observation first approach. If someone's haemothorax was less than a third of their pleural cavity, they would kind of watch and wait and manage conservatively, not stick a chest drain in. So they pulled up 43 patients who'd had a traumatic haemothorax. 39% were managed conservatively, so only 4 got a chest drain. No infection in any, no chest drain complications. 3 patients died, but that was thought not to be related to the chest injury. So what they're saying, yeah, conservative approach is low risk for development of pleural infection. So I guess useful in the non-major trauma patients in that we don't have information about the patients that went to the major trauma centre, but we can see that people who have not had chest drains have not then had some gnarly infections from the blood that's in the pleural space. And definitive RCT welcomed, like all papers finished with more research is needed. I guess also like there has been some stuff in the last couple of years about conservative management of pneumothoraces, which is leaning towards kind of leaving them conservatively managing, so pulling off those lower risk hemothoraces, and pneumothoraces seems to be the future. Kind of let your body just sort them out because the interventions are really invasive. So yeah, that's going on for things in your pleural cavity that shouldn't be there. We're doing less and less. Next piece. Outcomes from, let me find it, outcomes from out-of-hospital cardiac arrests in nursing and care homes, a cohort study by Batten, Brown and Cooper. So cohort study, it's not trialling an intervention, it's describing a situation. So what we're seeing a lot of at the moment is trying to get a more nuanced picture of out-of-hospital cardiac arrest. There's so much research going on and lots of information gathering. This is looking specifically at people who've arrested in care and nursing homes, and it is basically like looking at all the context and the outcomes and what was done. So, as they say, they aim to describe the characteristics, treatments and outcomes of individuals sustaining out-of-hospital cardiac arrest in nursing and care home settings. So they use data from one of these data sets that gets saved nationally, which is the out-of-hospital cardiac arrest outcomes registry for England. So all that data is harvested, kept somewhere where researchers can then access it. They pulled out all patients 18 years old or over who had a cardiac arrest in a nursing or care home from 2015 to 2021. Note as ever that includes COVID, although they don't think it made all that much difference. Excuse me. So they pulled out 4,779 patients. Right, I'm just going to give you loads of percentages now. So about half were women, 52.5% were women, 81.8% were 70 years old or over, 51.1% of arrests were witnessed, 80.2% had bystander CPR. An AED was not available for most of these patients, for about 90% of them. So there was an AED available in 426 of these arrests, and it was used 77.7% of the time when available. So it was used, an AED was used on 331 patients. 36.7% achieved ROSC, return of spontaneous circulation. 22.3% managed ROSC to hospital handover, so kept resuscitated and kept alive till hospital. And there was a 2.1% survival to discharge. So let's remember that's 98% of people that arrested died. 2.1% survived to discharge from hospital. So, first thing noted, as age increased, there was a decrease in survival and ROSC sustained to hospital handover. So, the older you are, the more likely you are to die. Other points, high levels of bystander CPR, I'm guessing because there's lots of bystanders in a care home, and they tend to have BLS training as part of their job. Also worth pulling out that they weren't able to ascertain whether these patients were residents in the care home, because you've had an arrest in a care home, you could be someone that worked there, you could be a visitor. So they don't have that data available to them. And yeah, so as they say, despite an apparent optimised community response, we observe survival lower than that within the general out-of-hospital cardiac arrest population in England. And one of their conclusions is there may be an opportunity to optimise the availability of AEDs within nursing homes, which is not the conclusion that I would reach from that. I think stating that the older you are, the more likely you are to die from a cardiac arrest is... that's, they're describing the data, that's not a value judgment. But that's also the human condition. I felt very defensive about this paper actually, and I think on reflection the paper's decent. Like, it's giving us a nuanced picture of what an out of hospital cardiac arrest looks like in a nursing home. They suggest AEDs and more training for staff in BLS, but they're not like aggressive with it. I think people that have worked pre-hospitally have experience of inappropriate resus attempts in care homes, and I'm definitely bringing a lot of that with me to this paper. The first proper arrest I worked was a 100-year-old in a care home, and a carer had started CPR, so we continued CPR. It was 15 years ago, so we had less autonomy to stop resuscitation, and we broke all of his ribs. I intubated him. I put a cannula in his jugular, and he died because he was 100 and his heart had stopped, and I still feel horrible about it. And I think it's a really common experience to do these arrests in a nursing home, and you're like, what are we doing? And I think there is more space now to turn up and be like, this is not workable. But I think it's that background that makes me and others quite prickly to this kind of stuff. Like, is it a problem that the older you are, the more likely you are to die, or is that the human condition? Like, is there a problem with poor survival rates of cardiac arrests? And is the answer to that possible problem that we need more AEDs in nursing homes? I'm not sure. I don't think so, actually. But I do think this wasn't really their point. I think it's more interesting in terms of ambulance perspectives of care home arrests. I do think things have got better. There is more autonomy to make those decisions now, and I don't necessarily think the decision making should be on some like underpaid carer who's come across someone they have a years long relationship with in cardiac arrest. I don't think it should be their decision, but I do remember feeling very frustrated during that arrest, and the staff were all crying because of the shock, and it's like, it is a shock. Is it a big shock? And like, why is there no DNA CPR for a 100-year-old? So so maybe the takeaway could be more about, are we making sure that we're having DNA CPR discussions with everyone that is in a care home? Not to say that they all need one, it's up to them, but like, are we having those discussions, or are there people being left without them, that CPR has no chance of working in? Thoughts? I'd be interested in anyone else's take on it, but I feel like that's the general mood of people that have done this stuff pre-hospitally. There was even a bit of me when I was reading this, it was like, yeah, but the people doing this research are not the people that have to break the ribs of people in the 90s. So it was like, I think the researchers for this are cool guys. Thank you for doing this research. Why am I so defensive? Clearly there's an issue here. So I think my takeaway from this has been a reflection on all of those experiences rather than this research itself. So yeah, I'd be really interested in other people's opinions about that. Phew. Okay, understanding cardiac arrest dispatch of physician, paramedic, critical care hospital teams, a survey-based evaluation by Morton et al. Off of East Anglia. A real quick one. Basically, like, crit care dispatch is relatively new. It's an emerging field. This is a survey of about 20 dispatchers who are mostly clinicians, aiming to understand decision making around crit care dispatch in out of hospital cardiac arrest. They found quite a lot of variation. That only 100% agreement in dispatch was if there wasn't a witnessed arrest or if there was a ROSC. Other criteria was not unanimous. So they took into consideration things like whether it was in a public place, the age of the patient, the preceding events and history, but there wasn't standardisation there. So, and the authors highlight this as an area for improvement, standardisation, which makes sense. It's fairly new. It's not going to be standardised. I guess the extent to which there'll be a protocol, let's see. How much do we need to keep some kind of clinician autonomy? We'll see. And the next one is ultrasound time. So diagnostic accuracy of pre-hospital ultrasound in detecting lung injury in patients with trauma, a systematic review and meta-analysis by Sen, off of Leeds, Emerson and Franklin. So lung injury in trauma patients, we're thinking about pneumothorax, hemothorax, pulmonary contusion. So they pulled out a systematic review, so they pulled out 6 observational studies around these types of injuries. 4 of them were decent. There was only enough good data really to consider pneumothoraces rather than the others. They found that pre-hospital ultrasound was highly specific but lower sensitivity for picking up pneumothoraces than in hospital. And there's a big research gap in that they weren't able to look at hemothoraces or pulmonary contusions because there's not enough evidence. So they are saying, let's get some pre-hospital education and training. There's an expanding field. Let's get good at pre-hospital ultrasound. Then we've got data, then we can do the research, and then we can make a decision. So in the meantime, we have got one to add to my list. Hospital pneumo. Oh no. There we go. Bish bash bosh. This whiteboard is for teaching my 4-year-old to write. So they're used to it now. It's coming home from school like, where's my whiteboard gone, mummy? Well, I had a half-hearted joke that I had to make for 4 people on the internet, kids. So get used to it. Next one. Right, there's 2 left. We've got oral TXA for immediate use in major trauma, implications for mass casualty events by Warner, Lowe and Barnard. So tranexamic acid we know it significantly reduces 28-day mortality in patients with traumatic hemorrhage. There's been some huge international studies with hundreds of thousands of participants. We know TXA is good. We know it's time dependent. There's a 10% reduction in effectiveness for every 15-minute delay in administration, which is why pre-hospital stuff are so important in the administration of TXA, and why it's a sexy ambulance drug that wasn't there when I started, is there now post-crash 2, and now we are also getting to slightly more thoughtful use of it. So there's been some changes in ED around like dosages and stuff, and here we are looking at whether it can be given orally as well. It's usually given IV and IO. There is an IM version of it increasingly available, which I guess means a tech could give it. This is looking at oral access, so it's basically saying like one person with one major trauma patient with massive hemorrhage, quite easy to give TXA to. If you have a mass casualty event and you have 200 people, this is significantly more challenging. So this comes out of some of the reflections on the Manchester Arena bombing in 2017. So the barriers to quick delivery of TXA are IV and IO access. Can you get it in a poorly patient? Are you someone that is able to get it in the first place? So if you don't have a paramedic crew, for example, or you have a paramedic crew, they're just really difficult to get access to. And also if there's a high number of patients, you just don't have enough stuff. You don't have enough stuff. So is there anything we can do to improve our provision of TXA when lots of people need it at once? Basically, if oral TXA is available, you can give it to all the conscious patients that can follow instruction, and that's freeing up clinicians and equipment for unconscious patients who will also benefit from TXA. So potentially really useful. So it works already. It's slower to reach the therapeutic concentration. So yeah, where they get to with this is it might be that you can give it to people orally, but they need to chew it a bit like aspirin in ACS. Which is called dose dumping, which is real macho and I've never heard before. So we might need to get people to chew it to dose dump, but yeah, this is potentially really useful for mass casualty events. Having like 100 tablets is so much easier than getting access on 100 patients and administering it. So yeah, that is useful if you're thinking about mass casualty events or working in Antarctica. So one of the authors, Warner, now then, let's see. Matthew Warner works in the Emergency Department, British Antarctic Survey Medical Unit, Plymouth, UK. That's cool, isn't it? And there's actually, the last thing was that the reference section is kind of cool in this. One of the papers that Warner was part of writing, Optimising Remote Healthcare Delivery in Antarctica, a review of the current capabilities utilised in the British Antarctic Territory, published in the International Journal of Circumpolar Health in 2023. I love that, and that seems like maybe a rabbit hole that I will disappear down this afternoon. The other reference, so the Manchester Arena bombing in 2017, the emergency response to that was evaluated in great detail. There was an inquest that went on for a long time, and I think it's accepted that the response was inadequate from a number of different ways. Lots of people I know followed the inquest as it happened because, you know, especially it's like a big northern city. I work in a big northern city, and there's a sense of like that could have been anywhere, and what would the response have been anywhere. So a lot of people followed that in this field, and a lot has changed since. A lot was learned from it, and things like this are the downstream of that. So we're seeing it kind of percolate through into practice and change practice. So yeah, the last thing is there's a paper I wasn't aware of actually that was published in the EMJ in 2021, Healthcare System Impacts of the 2017 Manchester Arena Bombing, Evidence from a National Trauma Registry, Patient Case Series and Hospital Performance Data. So I didn't realise that there's something all in one place. I've also not read the inquest report as well, so those are probably two good places to start in terms of understanding this terrible event, the inadequate response to it, and then what we can learn from that. It's kind of event that like kind of influences practice that hopefully you only see once in a career. COVID was something similar as well. I guess it's like seeing these huge things, the immediate fallout, and then understanding how that plays into the like evolution of systems and hopefully improved care in the future. Okay, last one. It's just a teeny one. It's not actually published in here. It's one of the ones that's in like the International Journal Roundup. Association of Pre-Hospital Hypertension and Bradycardia with Stroke, a single centre observational study. That was from Hong Kong. And quick takeaway, one sentence: pre-hospital hypertension and bradycardia and impaired consciousness level associated with significantly higher risk of stroke. So if someone's unconscious, hypertensive and bradycardia, think stroke, get the bat team in, bish bash bosh. Right, that's all. Thank you so much for watching, both of you. I will be back soon with May 2025, and then I'm almost caught up, so that's great. I spent this weekend in the countryside putting the world to rights next to a fire with my friend, and I'm in a really good mood now. And that's probably my chosen way of avoiding burnout in this job. So I'm in a really good mood. I feel really positive about work. I'm sure everyone watching has their own version of sitting in a field and talking about everything, but maybe a reminder that if you are feeling a little bit stressed, maybe go and sit in a field, because I think sometimes you need reminding. If you're really stressed, it's easier when you're a bit stressed to do something about it, but when you're really stressed, it's not that easy, and I've seen a lot of people burn out. So that's just my quick check-in. Time to get to the countryside. See you next month. Thank you for watching.